If you would, go ahead and place your name and campus in the chat if you have not done so. Place your name and campus in the chat. All right, it's official start time. Good evening to everyone. Hopefully everyone is doing well. And welcome to, I believe we're down to week number 9. Let me go to our announcement sections. Hopefully you've read the announcements. We did put like a roadmap in for the next couple of weeks. So of course, week 9, we actually finish up our content tonight. And then I'm gonna share my screen here. As always, these sessions are recorded and they are viewed by the attendance administrators. In the event that you have to be away from the camera, make sure you put a message in the chat to myself just stating, why you're not in front of the camera. If there's a connectivity issue or any other issue, please place a message in the chat to myself describing what the issue is and what's going on. So we're in week number 9. We finish up our content tonight. We're going to look at that functional ability. And as we say those words, functional ability, physiological changes, and medications, just be thinking about what other words, what that really means. Functional. What things do we do that's functional? Like me, just that movement of my hands. Think about the movement. We really don't really think about this, but in order for someone to chew food, what functional ability do they need? The teeth to work, that joint, that mouth to open and close, right? And so sometimes it's not that that person can't, and it could be that they can't actually do the functioning of picking up the spoon or fork or the food and placing that item in their mouth. But what about that opening and closing? They have something going on with those joints in that mouth. So think about what functional ability really means. So piece that out, and then it'll help you to make a better connection of what we're talking about when we say functional. Those physiological changes, how does agent affect that heart rate, that peristalsis, and then excretion rate from the kidneys. So we're going to talk about all of that, and then we're going to look at some medications and how they are affected because someone is older. And then, of course, next week we do have the last exam. Exam 3 is next week, and then for sure, some of you I may have even heard already, but for sure by next week, you should be hearing information from your campus deans that gives you guidance on your HESI, which for us it is week 11. Like where it is, the time, and all of that. Those specifics come from your campus dean. So just make sure the information that you have is specific for your campus. But campuses, the instructions and the dates and times, they are different. So for example, if I am on what's the campus? Port St. Lucie campus. I may be taking my HESI for this class on Monday, and you may be taking your HESI for this class on Wednesday. So just make sure that you don't get confused or mixed up with what you're supposed to be doing for your campus. And then, of course, week 12, we do meet to discuss just a few items. We wrap it up for the term. All right. And so let's go ahead and get and start talking about our content for the week here. So as always, we start with the HESI highlights. That's on it. I didn't piece those out on the slide. It's still all on one slide, but that's fine. It's the same information. So be looking at that information. So we're going to be talking about this anyways, the cardiovascular system tonight, respiratory and musculoskeletal. So, be thinking about, well, what happens with that older person? So a test taking tip for you all when we are answering questions, remember your population, or to put it into context, this person is older. So take that in consideration when you are answering those questions. Sometimes we're so quick to answer, but put it into context. An example, what I mean by context, is this person an adolescent or are they 80? So another example of context is a person that just had, some type of heart procedure done or heart surgery, and they are 2 days post-op versus a month post-op. So those things that we might do may be a little bit different based on that context, based on when are we actually that time frame we're talking about. And like I said, we're going to get into these details more on into the PowerPoint here. So again, functional ability. Think about all those things that you just did. You sat in your chair, you stood up, you picked up your bag, you punched the computer to log in. All those things are functional. And think about what things that your body had to do in order for you to stand up, in order for you to move that chair, in order for you to plug your computer in, and so forth and so forth. So, but just be thinking about that. These are our learning objectives. Of course, we are looking at the normal physiological changes, but specifically with the aging population. Okay, so the physical, psychological, and cognitive and social abilities to carry out daily activities. So think about those things that we do throughout the day within the last hour. You may have been in a car, you may have had to open that car door, you may have had to feed the dog, open the dog food container, you may have to turn the faucet on, you may have to have read something. So just think about all those things. It has a big impact on the independence and quality of life if a person is unable to do those things, if they don't have that functional ability. The WHO defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Factors that affect functional ability. We want to discuss effects of normal aging, disease, changes in social status or economic status. Because just think about if the older person isn't able to complete the tasks that are required for them to complete their job. Not only that they may be at the retirement age, but what if they're not at the retirement age and they can no longer complete those tasks? How does that affect that person's social and economic status? Loss or gain of health. What if a person, they've been healthy, they've been able to go to work, drive themselves to work, complete the task, come back home, take care of themselves. But what if they have that broken hip? What if they have that kidney disease and they're not able to, and they're sick and they're not able to go to work to perform those tasks? We may be on different ends of the spectrum at different stages in our lives. Okay. So, what are some things that when we think about the nursing process, what are we going in and assessing? What might be some of the assessment findings in reference to function? Or specifically, also, what things should we be making sure that we address and assess in the older population so that we can come up with some interventions, some things to do? How much assistance does this person need to eat? Here in the picture, you have a person with a spoon and they are guiding their hand. And so do they have limited mobility with that joint? Do they have Parkinson or disease process where that joint hurts, or Parkinson that they have those tremors? What is it? And so is there anything, is there any adaptive equipment that can be used so that this person can feed themselves? Because if we have an adaptive equipment for the spoon, fork, or knife, then this person might not need assistance for someone to feed them. So an example that I've seen with the when someone's eating, I've seen several, and you all probably have too, with eating. They have, like, he has a bowl there. They even have plates like that. I think that's soup. So more than likely it's in a bowl. But then they have plates that are like bowls. But what happens with the plate is not flat. It has that rounded edge. So if a person has limited mobility, that rounded edge, when that person pushes that spoon or fork up against the edge, the food actually gets onto the utensil rather than a flat plate. They push and push and push. They may push the food off the plate. So that's an adaptive equipment. Another thing that I've seen is a person maybe that has Parkinson's or some disease process that limits their range of motion, and they may spill their drink. They may have lids on the cups or the whatever that they're drinking out of. And so what that does, a lid is on it. So it has that small little opening there. Another adaptive equipment is on that spoon, fork, or knife, they may have, it looks like a sponge, pool noodles. They can, I know that's not what it is, but to me, in my mind, that's what it looks like. They add that, like a pool noodle, around the handle of that spoon. And so that person has a better grip. And so they're able to feed themselves. So as we're going in to assess our clients, be thinking about, hey, can this person complete these activities themselves, by themselves? And if not, how much assistance do they need? And if not, can we have some type of, is there an adaptive equipment device out there that this person can use? And have you all seen any of these in your facilities that you've done clinicals in? Any adaptive equipment? If you have, please come up here and share what you've seen. And there are all different kinds of things out there. Because who would have thought that, having a plate that had an edge to it? Because, for the most part, we just pick our food up with that fork or that spoon. But having
I've
that,
seen spoons that are thick like that, but
mm-hmm,
they also have like a center of gravity. So
mm-hmm,
as the person is like shaking, like the spoon doesn't spill, it like moves
got
to
it.
keep the center of gravity. They're pretty cool.
Exactly. It is. It's like, wow, who thought of that? And I'm sure some nurse did. So be thinking about that, that functional part. Things that we don't really think about. Get, like I said, mentioning putting clothes in the washer. You're picking up, you're having to turn the dial. So think about those functional things. So we've talked about this, says discuss adaptive equipment such as utensils for a patient with a tremor. We talked about grab different plates, the different spoons, but also grab bars in the bathroom. They may need a walker. Sometimes I've seen like the tennis balls on the bottom of the walkers, on the legs of them, the foots of them, and there's so many different adaptive equipment that's out there. Okay, so screening for functional deficit in older adults should be a part of our routine care. We do want that person to be as independent as possible. So we want to assess, are there any deficits? Do they need any assistance with the activities of daily living? And what are they? It's putting on all those things we just talked about, putting on our clothes, ironing our clothes, bathing, dressing. And so if a person is unable to complete that range of motion, to bend, how they turn it, they can't use that hand, how they turn it on the water. So, and then how they putting on their shirt, do they have limitations in the range of motion of their shoulder? How they put it on how they dressing. So bathing and dressing indicates a decline in basic ADLs and requires further evaluation. So if a person is needing assistance and they're not able to, we go and we check the grip, we do the range of motion, determine whether or not it's full, partial, and all of that. If there's a decline, there's going to also be a decline in the ADLs, which there is going to require further assistance for the evaluation and also assistance from us. All right, so this says discuss other healthcare team members. So think about, I gave you all different kind of examples of where someone may have a decline in functional ability. So who else on the healthcare team might we add that this person might need to be assessed, or they might need to assist with, for example, the person has loss of use, of balance, or motion. Who else we might need to bring in? More than likely, they'll get a referral for who? Who else on the healthcare team? Well,
Occupational
uh,
therapy,
occupational,
physical therapy,
physical. Yes. Okay. Good.
probably dietary.
Okay. Exactly. All right. Great. So, what are some disease processes? I know we mentioned Parkinson's early. What are some other disease processes that might limit someone's functional ability to pick up that spoon, put on those clothes? What are some other disease processes? So,
A
put it in the
stroke.
chat. I'm sorry. Go ahead. What did you say? But everyone put an example in the chat where we
I
can
said
get
a stroke.
a stroke. What are some other disease processes that might limit someone's functional ability? So put it in the chat. She said a stroke. Let's see what you're saying. Traumatic brain injury. Okay. And just put it out so everyone can see it as well. MS, stroke, dementia. Got it. Yes. Okay. Good. We really, don't think about, as we do all of these things throughout the day, if we couldn't do those things, if we couldn't move our arms and legs. So any disorder that deals with the bones, you all, and then we did mention dementia, but anything that deals with those bones, those joints, because remember our musculoskeletal system, it allows us to move. It gives us our shape and our form. And also, what does a person having missing toes, does that affect their functional mobility? And you can come off mute. I see someone's putting it in chat. What are you all saying? Yes or no? If they're missing toes, does that affect a person's? Yes, it does. So we are fearfully and wonderfully made, and these little things, yes, it keeps us upright. It affects our balance. Rheumatoid arthritis, osteoarthritis. If someone's had recent falls, they may need, if they have, they may need a cane or walker. They may have some other devices out there that this person might need. But any disease disorders that has to do with mobility and movement. Encouraging participation in activities promotes function and independence. Sometimes it's just encouraging them because we do want them to be as independent as possible, of course, within the realm of being safe. And sometimes we just need that encouragement, just, to know that, well, hey, if after you work with therapy for a while, ask them questions, you may build up that strength. If they've had a stroke, they may build up that strength so they can use that side again, or they can have an increase in ability to use that side. It might not be the full ability, but encourage that client to participate in those activities. Because a lot of times what you see when therapy comes in, the patient, they don't want to participate. And we do want to support their autonomy, but we want to make sure they understand why these people are coming in, having them to put socks, roll up socks, or put socks in a basket, or because it seems like the things that they have them doing is like, why do they have them doing that? But they don't. That person might not realize that those tasks helps them to gain that functional mobility again. So encouraging them to participate because we want them to be as independent and safe as possible. We do want to do that. Okay. So what physiological changes of aging are there? So this slide is just saying, making sure that you study for the exam and the HESI prep. And of course, your NCLEX is coming up pretty quickly for you all. So make sure that you're going back through all of your content. So each body system includes 3 sections: overview of the system, expected age-related changes, and then we have a picture. I think all of you all have access to the NCLEX book. Common disorder. This is just how it's set up. And it has flashcards, and then you can use a concept map to write out so that you can see if you can make the connections with what's going on. Okay. So we have a picture in the shadow of someone looks like they're running, and this person is using a walker. What changes to function? That hip joint might not be, moving like it should. It looks like their gait is wide. And so just what changes occur? All right. So here it is. We want to do some matching. So you all, let's see how we're going to do this. Just do some jot noting. We'll give you about 3 minutes to look at this. Do some on your own paper. Just jot down what you think matches each one. Like for bone calcium, which one on the right side matches that? So I'm going to set it and then we'll let you check your answers here in a moment. Let me set my timer for 3 minutes. We'll give you a little time. Let me get to my little clock here, you all. So just do some jot noting on your paper. Timer. Okay. I only made it. Okay. I'm gonna go on mute, give you time to think about it. All right, let's see how you do. Look at your paper and compare. Okay. So that decrease in bone calcium equals decreased bone density, which leads to osteoporosis. And so we know that that osteoporosis is softening of those bones because it doesn't have that calcium in our bones, make our calcium makes our bones hard. And so if a person that has osteoporosis, the least little bump on something, like we bump our toe or our foot, or we end up banging our arm up against a table or something, if if those bones are soft enough, they will just break from just that bump. So that decrease in calcium. What about the decreased fluid I can't even say the word, you all, the vertebra, where that fluid has decreased. Have you ever heard people say, well, I've gotten shorter? Then you measure their height. Well, I used to be. That's because you remember those discs, when they're nice and full of the correct amount of fluid, they're nice and they have the space. But over time, as that fluid, I don't know if you see my finger, that fluid decreases, that disc size decreases too, which equals that decrease in height. So when you measure them, yes, they are shorter than they used to be. That decrease in tissue elasticity, decrease in mobility and flexibility. They decrease in muscle mass. They have decreased strength. And so that's why a person might be at risk for falls. And we can bring in physical therapy as well to help do some exercises to build up that strength. And then a decreased muscle blood supply, we will have decreased muscle strength. Okay, I have to turn our little clock off. Okay. So muscle skeletal disorders, osteoporosis, like we said, is that loss of bone, that bone mass. That bones get soft. And then as a result of that, there is weak and brittle. So you look at the normal bone. It's all filled in. And if someone has over time, it decreases. And then someone ends up with osteoporosis, that bone, that mass is really, really small or less. So who on the healthcare team do we need to bring in? We said physical therapy. Who else to address this dietary calcium and vitamin D?
Dietary.
Got it. And then you will see sometimes patients are prescribed. I don't know if you all have administered antacids because they're full of calcium. Person didn't have indigestion or heartburn, but they're taking because those things are jam packed with calcium. So you will see people taking those. And even some seizure medications. Okay, so that's fine. We talked about that vertebra. That fluid in there decreases over time, and then also sometimes you may see that rounded curvature. I have to find my and getting older, so it's like, oh, I have to catch myself, make sure I'm not slumping, because it's just that you can have even as a child you can have that functional scoliosis where it's because of slumping and posture. But even as an adult, I don't know what it is, but we just kind of have that slump posture. But over time, it can lead to kyphosis, and that's that rounding. So this is looking at musculoskeletal conditions, healthy bone versus the osteoporosis bone, which you just saw in that other slide. That osteoarthritis, that person doesn't have it as much cartilage in between those joints, so that hurts. So if you're hurting, more than likely you're gonna not move as much as possible. So we see patients, they are on medications for the pain, and then that RA, they have the inflammation. Okay. Worse after rest, pain relief with movement. You may see them also on NSAIDs and corticosteroids. So age-related changes related to the heart, cardiovascular changes. Changes include decrease, you all, in heart muscle tone, decrease in cardiac output, a decrease in elasticity of the heart muscle and blood vessels, and then an increase in hardening of those arteries. So the only thing that increases is the chances of those arteries getting hard. So as a result of that, had the person having decreased muscle tone, they're at risk for heart failure because that heart is not able to pump with that full force like it normally would. And then, which also can lead to decreased cardiac output. That heart is not pushing the fluid like it's supposed to. So that's all that fluid backs up, and it leads to a decreased blood flow to particularly the peripheral. So therefore, if we're checking those posterior tibial dorsalis pedis pulses, they may be weak or even absent because that person has a decrease in cardiac output. So you want to make sure that we're checking those pulses. And if the person has a wound and they have the decreased cardiac output, a wound on their leg, then that wound is not going to get as much blood flow, those nutrients that it needs to heal. So it kind of goes into like a domino effect. Older adults have a reduced or decreased or not as much cardiac output, which may result in increased chance of heart failure. Doesn't mean that they will automatically get heart failure, but because, like we just said here, that decrease in heart muscle tone can increase the risk of heart failure. That decreased cardiac output decreased blood flow to the extremities. So again, older adults have a decrease or reduced cardiac output, which may result in increased chances of heart failure, which also leads to decreased peripheral circulation, which means when we check those pulses, they may be faint, absent, or weak because that fluid, the blood flow is not good to that area. So we do want to make sure we're checking those pulses and making note of what they are: weak, absent, faint. Okay. So bar right here. So heart failure. Injuries causes the heart to be ineffective. The heart tries to work hard, but actually it ends up injuring itself because it's overworking. The heart is not effective to get all the blood out of the chambers. So we have that heart just pumping, but some of that fluid, the blood is sitting in the chambers. So what happened? That fluid is backing up. And so since the blood with oxygen is coming out of the lungs, the blood backs up in the lungs. When we assess the person, what finding do you think they might have? They may be complaining of shortness of breath. It can also continue to back up, causing the legs and abdominal edema. Hence is why it's so important to do your assessments. Note those findings. Person complaining of shortness of breath. The pulses may be weak. There might be edema. And then for the edema, make sure that you're noting the amount of edema. Is it pitting? Make sure you describe it. That's just a picture showing what we just saw. Describe the edema. Is it pitting or non-pitting? Okay, so fluids and electrolytes. So blood is the fluid the heart pumps out fluid around the body to deliver oxygen and nutrients to our tissues so that they live. So our brain, our baby pinky toe, and everything in between. What that blood is carrying, all those nutrients, so our insides can live. If the heart is working too hard to push all of the fluid, what can we do? What's the main intervention that we can do to help our age slow kidneys to get rid of some of that extra fluid so our patients can breathe and move around? What can we do? So think about it. They're not going to be perfusing. So they might not be, the kidneys might not be excreting like they should. So that waste stays in. The heart is not pumping like it should. So that oxygenated blood is not getting to all of the body parts like it's supposed to. Okay. So elderly do not present with illness the same as the younger population. So they might not, if they're having something going on cardiac, they might not have the classic chest pain. We know that ladies also might not have the classic chest pain. But if a person is elderly, they might complain of nausea, fatigue. They may have that confusion, and they may complain of heaviness, like something. Oh, feels like my chest feels heavy. It feels heavy. It feels like something sitting on it. They may not specific. Some people even say elephant. You hear people say that, but the thing is, they might not say that they have that classic chest pain. Okay, so this slide looks at the respiratory system with aging. What happens? These things decrease the number of cilia, the strength, capacity, the number of macrophages, capillaries. And so what does that do? Let's see. Let's see this one. Okay, so the decreased number of cilia leads to decreased ability to trap the debris. Remember the cilia, those little hair-like things that's there, and it traps debris. So if there's a decreased number of them, there's a decrease in ability to trap the debris. So for the macrophages, it leads to increased respiratory infections because there's not enough of them there to fight off the infection. The decreased muscle strength and endurance leads to a decreased ability to breathe deeply and do that cough. So, we encourage deep breathing and coughing, but they might can't because that muscle strength has decreased. And also decreased tissue elasticity in lower lobes leads to an increase in pooling of lung secretions and decreased gas exchange. Remember, that person can't expectorate, get that fluid up out of the lungs. They can't cough. So it just sits there. And as a result of it, it affects that gas exchange. So hence the body may speed up. We're counting their respirations. It may be above the normal range because the body is trying to get rid of those secretions because that elasticity is not there. O2 sat might be low. And then when we listen to those lungs, we may hear adventitious breath sounds. It may be, may hear crackles or something like that. So for pneumonia is an acute inflammation of the lungs caused by bacteria, viral, it can be caused by chemical agents or mechanical agents. In response to the agent, the alveoli and the bronchioles become clogged with a thick, fibrous substance that decreases the ability for the lungs to do the gas exchange. So these things, the bacteria, it makes the lungs not do what they're supposed to do. And the lungs are supposed to be doing a gas exchange, bringing in oxygen, expelling carbon dioxide. But if there is a bacteria, viral, a fungi, or chemical or mechanical agent there, then that gas exchange is not happening. Hence, the person might have increased respiratory rate. They might have a decreased oxygen sat, and more than likely, you're probably going to hear some adventitious breath sounds. So, and like mechanical agents or chemical, it can even be. I have to be careful with air fresheners. I love the way they smell, but that's what's going on now. I saw some air fresheners, and I was like, oh, these are in a little satchels. I knew I couldn't do the plug-ins, but I saw these are in the little bags. I call them satchels or whatever. And hence is caused this respiratory stuff. So I don't know. I guess my gas exchange is overload. So I'm taking in too much of that, whatever that agent that's in the air, the fragrance. And as a result of it, it's causing a buildup of fluid. So that's an example of those mechanical agents or chemicals. When you're cleaning, do you have a mask on? We want to encourage our clients maybe to wear masks because those chemicals, those scents and fragrances from the chemicals that we use, it can get inhaled and cause problems. Okay, so some symptoms that we might see: that person might be fatigued. The person may have an increased heart rate. They may have a fever, and then if we do blood work, that person might have an increased white count, cough, and they have a cough. So making sure that we're doing that in-depth assessment findings to verify. Elderly may not have a high fever related to changes in immunity. So you might not see that high fever, but that heart rate is going to be up because you remember the body tries to help itself to stay well. And so it speeds up because it's thinking, hey, we need to fight off whatever, or this person's not, the gas exchange is not happening. Okay. So these are some more signs and symptoms that we might see as we are assessing our clients. Okay. So let's look at chronic obstructive pulmonary disease. What is COPD? What is this? What are some signs and symptoms? Okay. So COPD is really an umbrella term that's used to include emphysema, chronic bronchitis, and emphysema of elasticity of the alveoli results in an overinflation of the air sacs, which leads to an ineffective gas exchange. So this person is holding on to that carbon dioxide. They're not expelling it like they're supposed to because there's an overinflation. Chronic bronchitis involves inflammation of the trachea and bronchioles. Okay, so some signs and symptoms will be a productive cough, wheezing, shortness of breath, on exertion, or even fatigue. Interventions include bronchodilators, anti-inflammatory medications, educating, if the client smokes, educating them on smoking cessation so they can stop smoking. And then think about energy conservation. Just you will have a conversation about what do they do from day, throughout the day. And then have them to create some type of roadmap so they can break those things, those tasks up because they get fatigued because they can't, that gas change is not happening. So what'll happen is a person will just stop doing those activities of daily living. So you have to have a conversation with them and just think it through. Well, what can we do to for you to still be independent? How can we break these tasks up so that you can still do what you need to do? Bathe yourself, cook for yourself, and things like that. And then the breathing technique is the pursed lips and the tripod breathing that helps them with that gas exchange. They may even need anxiety medication or some other anxiety tips or information. Because I don't know if you've ever been short of breath before, but if the person is short of breath, you get kind of anxious. So just imagine being short of breath, for all the time or most of the time. That person may need some anxiety tips or interventions. They may need the intervention might also include medication. Encouraging to take those rest breaks. How how we just want to get everything done, encourage that person to take those breaks. And then that metabolic demand can result in weight loss. We're gonna bring in that dietitian to see what can this person eat that so that it still meets their nutritional whatever that nutritional requirement is. That dietitian may have to offer this client some finger foods. They may have to have frequent meals, but that dietitian can, because more than likely this person is not going to be moving around, and they might not even eat that much because they are having trouble with that gas exchange. They are short of breath. So, do I eat or do it could? But if I eat, I'm gonna get short of breath. So the person will just not eat, which will lead to the weight loss. So you can bring the dietitian in to assist with and to identify an alternate diet, food options for that client. Okay. This slide is showing us, let's see, fluid help kidneys filter toxins and medications. We'll talk a little bit more about that. Oxygen, dry mucosa, fluids keep moist, drink water between meals, need room for food. Okay. When reviewing a discharge plan for a client with COPD, the nurse should anticipate that the client will do which of the following. Okay. So in the chat, just put A, B, C, or D, and you can check yourself when I show you the next slide. When developing a discharge plan to manage the care of a client with COPD, the nurse should anticipate that the client will do which of the following. So put it in context. This client has COPD and they're going home. They're getting discharged. Okay. Put A, B, or C, or D in the chat, and then you can check your response here. It's going to put on like 30 seconds. My little timer. Okay. Okay. Let's see. How do we do? Develop infections easily. Because remember, we talked about what COPD is. Is that gas, it's problems with that gas exchange. What happens? Those alveoli are there, and that elasticity, there's overinflation. So there's an ineffective gas exchange. So that fluid and things have the potential to pool there. And so as a result of that, person may end up with infections easily. Now, meaning they would, but a client with COPD is at high risk for development of respiratory infections. They are high risk. COPD is a slowly progressive, therefore maintaining current status, establishing goals, that the client will require less oxygen or unrealistic expectation, because remember, this person, that gas exchange is not happening like it should. So whatever, they more than likely are going to require oxygen. And so we do have to be careful with turning, and healthcare professionals, they pretty much know that someone that has COPD versus someone that just has shortness of breath and they're on oxygen. Normally, if someone just has shortness of breath, usually the doctors will order for the oxygen to be increased. Someone with COPD, you don't increase the oxygen, because what'll happen is the opposite effect will happen. That person will have a decreased drive to breathe because of what's going on with those alveoli when someone has COPD. Okay, so here's another one. Let me start my timer and restart. Let's see here. Okay, so In the chat, just drop one, two, three, or four. We'll give you 2 minutes to read through this one. Let's see here. Okay, let's check your responses. It is likely that the client is developing a secondary bacterial pneumonia. Pneumonia is the most common complication of influenza, especially in the elderly. The development of a purulent cough and crackles may be indicative of bacterial infection and are not consistent with a diagnosis of influenza or the flu. These findings are not indicative of dehydration. Decongestants and bronchodilators are not typically prescribed for the flu. Okay, now let's look at the GI tract. Okay, so the stomach is lined with a mucous membrane, which helps protect damage to the muscle walls. You got digestive juices, medications, and food like alcohol. Changes in older adults include a decrease in gastric secretions. We need those gastric secretions to help break down that food. Um, how are medications and supplements affected? How can they how let me just read what's there. Discuss how medications and supplements can damage the stomach lining. What does medications, what can they do? Look at the pictures here. It can make that stomach lining decrease. It can alter it, erase it, decrease it, reduce it. So think about NSAIDs, those aspirins, iron supplements. That's the same slide. Okay. Elderly do not present with the illness same as, younger adults. They may complain of generalized pain. They may have a decreased appetite, may have that weight loss, nausea and vomiting. And sometimes they don't even realize they've lost that much weight until someone calls out their weight. What? I weigh that amount? And so that weight loss is a big one. They may also experience nausea and vomiting, and they may have those tarry stools. Okay. So the endocrine disorders, the one we're going to look at is diabetes. Okay. Type 2 early signs and symptoms can be subtle. There's a decreased insulin production and an increased insulin resistance. Okay. Complication, there's decreased circulation. The heart is involved. There may be damage. Kidneys, there may be kidney failure because you have all this extra sugar floating around in the bloodstream, and it attaches to our different organs and it causes problems. Our vision may change with all that extra. That's why they want to make sure someone's diabetic, that they're getting those diabetic exams. Make sure they're getting their eyes checked, and there's a diabetic exam that the optometrists actually do. Because over time, if they don't control that sugar, it affects kidneys, the eyes, all these other body parts. Risk factors include weight, sedentary lifestyle. We want to encourage that client, if it's not contraindicated, to get up and move. Even if it's just walking to every room in the place that they live. They might, in walking in the yard, they have, a yard to walk in. And if it's safe, if it's not safe, just walk around in the house. Just so many days so they can get up and move. We want to limit those limit processed foods. We do want to do fresh if we can, but it's been winter time, so we've all been relying on those frozen or those alternate, canned fruits and vegetables and things. We may can get a few of them in the store this time of year, but they just don't taste the same. Interventions may include medication management. The person might be on anti-diabetic medications, oral, and they may be on insulin as well. We want to encourage dietary changes, emphasizing lean protein and plant-based foods. They need to be monitoring that glucose level. And then they will do that A1C to look back at their glucose is to see what they've been over the past 3 months. Okay. So this is just looking at hypo and hyperthyroidism. They're like the opposite. One will have constipation, the other one have diarrhea. One is cold intolerant, the other one is heat intolerant. So they're just actually the opposite of each other when you have hypo and hyperthyroidism. Okay, so let's talk about medications here. What are the rights of medication administration? So tell me some of those rights. I think now we're up to at least what, 8 or 9? What are some medication rights of administration, of medication administration? Yes, if you need to step away, go to the restroom, that's fine. Just put a message in the chat to myself. The right to decline, that's correct. To refuse, what are those rights of medication administration? The basis was making sure that you have that correct medication, making sure that that dose is right, you have the right person. But now they're a little bit more. The basis was making sure you had the correct patient, the correct medication, the correct dose, the correct route, the time, and documentation. But now, like you said, the person has the right to refuse, the right to know. What are some others that you all have come across? So I think it's 9 now. But at a minimum, these are the minimum medication administration rights that we need to make sure that this is correct patient. In the facilities, how do they identify who this patient is? We're just going in. Do they have armband? Do they have the name outside the door? Even when the name is outside the door and there's a 2 persons in the room, which name goes to which person? Is there a picture? We've seen pictures. Some facilities have pictures of the person. Okay. The liver is the primary source of drug metabolism. If the liver function is impaired due to liver disease, medications will be eliminated from the body more slowly. Hence, an accumulation or buildup. Hence, the person may end up with toxic levels of that medication inside of their body because the liver is not going to break it down like it's supposed to. And so, as a result of that, it's not going to be eliminated. So, it's like a domino effect. There's a decrease in breaking it down. And so it adds to an increased risk for that person, those medications accumulating in the body, which hence toxic levels. There are several medications where you have to draw the blood to see what the level is. And so you do want to make sure that those labs are being done as they should, because, if the levels are high, that means that this person is not their body is not breaking down the medications like they should, and they're not being excreted and gotten rid of. So what happens over time, you may start seeing mental status changes in this person. The person's gonna get sick because they're not excreting those meds like they should. So adverse drug reactions. What are older adults more susceptible to? Why are older adults more susceptible to adverse drug reactions? Like we just said, the body's not going to break down those medications like they should. This person may have, kidney disease, may have liver issues, because over time we know that all of these body processes, those processes decrease. Peristalsis, all these things decrease. So an adverse drug reaction is an unintended, potentially harmful reaction to a medication. So they take a medicine, for example, a medicine is given for hypertension. They take it and the blood pressure is lower, but it also causes the person to have some other reaction that it wasn't given for. Why are older adults more susceptible to adverse drug reactions? Because they may have this chronic disease process, it's like diabetes, hypertension, the list goes on and on. And with those disease processes, the organs cannot function like they're supposed to. For example, we just talked about the liver. The liver is not going to be able to break down those medications, which hence, and it won't expel the waste. So those things build up. So safe medication guidelines. They do have some screening tools. Stop, start, Beers criteria, list of medications that are potentially harmful or risk outweigh benefits. So that's if you work in a long-term care facility. I don't know if you all have encountered that, but they on a routine basis, they count the number of medications people are on, and they try to decrease the number of medications people are on because they know with the elderly, there's a decrease in all of these bodily functions. So these persons really don't need these medications. We need to get them off of them because the body's having is going to have a hard enough time breaking these meds down. So we have less medicines on, then we have a decreased chance for this person becoming toxic. It's sick because they're taking the medication. So they do a medication count. They look to see if there are any duplicates, see if these medications are really working. They try, they take them off of them because of those reactions. Okay. Pharmacokinetics, how the body acts on the drug. The study of drug actions in the body includes the process of absorption, distribution, metabolism, and excretion, like we just talked about. How does this person's body, break down this medication? How is it absorbed readily? These are things we need to think about. Again, that's why they want to do the pill count to make sure, does this person really need to be on these meds? Are there only any duplicate medications? Are we drawing labs to see if this medicine is at a therapeutic level? So, drug absorption and metabolism. First pass effect, decreased liver mass, because you have those decreased hepatic cells. A blood flow reduces first pass, affecting older adults, which can increase drug effects. Absorption changes can slow the onset of drug effects or make the effects irregular. So, like I said, we want to be all the time be thinking about, hey, is this person, doing our assessment? Has this person's mental status changed? Are we drawing the meds, the labs like we should? So, some examples of medications that may not be well metabolized by the liver that can lead to toxicity are digoxin. What are we supposed to be checking anyways before we administer the digoxin? We're checking their pulse. Some other medications that may not be metabolized or broken down by the liver, beta blockers, calcium channel blockers. These medicines all deal with the cardiovascular system. So they may not be absorbed or broken down or metabolized by the liver. Vascular changes, such as those that occur with atherosclerosis and arteriosclerosis, lead to a decreased blood supply to the kidneys. So in our vessels and our arteries and things, they're hardened or they're small, they're narrow. What does that do? It equals a decreased blood supply to the kidney. So if our arteries are hardened or they are smaller than they should, the blood is not flowing through like it should. Hence, a decreased blood supply to the kidneys. Decreased blood flow results in a diminished or decreased filter rate. So when a person gets those labs done, they can look and see what their filter rate is. Look and see what their BUN and creatinine, see if those kidneys are functioning like they should. Okay, let's see here. Fluid balance and aging body composition. Older adults have a lower volume of total body fluid than younger adults. This can affect the distribution of those medications. So for the most part, things decrease. And as a result of that, it makes things be hard to be broken down or excreted. Okay. So drug excretion, let's talk about this. Aging, reduction in renal function means more drug remains in circulation. So that's why you may see lower or different doses in a younger adult than you would do in an older adult. So the person might be on, for example, Tylenol. For a younger person, they may be on the whole 500 milligrams. For an older adult, they may be on the 325 once a day. But the doses um, are smaller because the drug stays in the body in circulation longer. Okay. Some examples of common drugs that can cause nephrotoxicity, or examples of drugs that have poor renal excretion are lithium, statins. Statins are given for cholesterol, NSAIDs, or ACE inhibitors. So you need to know these things, you all. So medications that can cause that nephrotoxicity, there's a decrease in excretion of these medications by the kidneys. And then as a result of that, they build up in the body. Okay, so how does a drug affect the body? Receptor sites vary in their responses to the medication. Medication responses are less predictable in older adults. So we want to make sure that we are doing our rounds, doing our assessments, and making note of, and then identify if we're getting some changes, differences. For example, the person's alert oriented times 4. We're back in, person's alert oriented times 2. Like what's going on? So make notes of those, and it could because it could just be those medications are building up in their body, and the body's not excreting them like they're supposed to, because the kidneys and livers and those things, the function slows down. Okay, how do we know if a medication is effective? We have an 80-year-old patient. They have been prescribed Lasix, and then 40 milligrams per day, and then 2 weeks for hypertension related congestive heart failure. We just talked about heart failure. The fluid, the blood is not being pumped like it's supposed to. What objective data could you use to evaluate the drug's effectiveness? Think about what information would you gather from looking, from doing the touch. Would it be edema? Do we see the person using accessory muscles to breathe? And then what's objective data? What would the patient say? Okay, let me stop here. So we do, let's see, we're almost due for our first break, and or we can push it on. We can stop for a 5-minute break and then come back and finish up, and then we'll take our other 15 toward the end, and or we can push forward. You all just got 3 minutes to let me know. So polypharmacy. Poly is many. So a lot of times when we see that, patients go to different doctors, and different doctors prescribe the person the same medication. So they take and they go to different pharmacies. They may go to, the Walgreens on this side of town. The next other side of town, they may go to a CVS. And then so hence this person has all these duplicate medications. So when they bring their medicines in, you're like, wait a minute, they have 2 prescriptions for Lasix, and they're written from 2 different doctors on different dates. So they have those multiple providers, and some of the medications may even be outdated. So we do need to look at those medications and make sure that this person, they're not double dosing, because they're at risk for that. So cognitive and sensory changes. Cognitive and sensory limitations increase the risk for medication errors. Because if I'm not understanding what I'm reading on that label, stop and check the chat, see what you all are saying. I may take that medication incorrectly because I am not understanding what it means to when it says twice a day or BID. That's one reason why you see that written out now. You There are several abbreviations that they don't use because the layperson, they don't understand what that means, and they will write out twice a day, take it, and then they'll be more specific, take one in the morning and one at night, so that there aren't any chances for error in taking this medicine. But if a person has cognitive change, they don't understand what that when they're reading that bottle that says the medication says take twice a day. If they don't interpret that correctly, then they may take that medication incorrectly. So we must assess that patient's ability to read and understand the prescription labels. It says take twice a day, when we can further ask, well, it says that. So when will you take this medication? And hopefully the patient say, well, I'll take one, in the morning, then I'll take one in the evening, or I may take one in the morning, I'll take another one, at night. So that's those statements indicate that this person does understand what those instructions on that bottle actually means. Okay. So also generic and trade pills, shape and color, they may change. Usually though, the pharmacy alerts the person. Like my mom, if she gets a medication that looks different, she's calling. But usually they put a label on there because she don't want to take it, because she has received medications that were the wrong medicines in the bottle. And so when she knows, and anyone, how pills look normally, and there's a different shape or color, usually the pharmacies put some type of sticker, or when you pick up that medicine, they'll say, hey, this is the same medication, but the color changes, the shape change. They usually go ahead and alert you with that. And so risks related to inadequate knowledge, use of over-the-counter medications, you know, see what they're taking. We want to make sure that nothing interacts with the other. Make sure that they understand what is this medication for and why should they be taking this medication. because we don't want to create a situation where that OTC, the over, excuse me, your counter medication is masking something. And so the client may have something going on, and we can't really tell it because they're taking, every day they're taking aspirin, every day they're taking, Kaopexate or whatever the medicine is that they're taking. Okay, so we've been in for an hour. Do we want to let's just stop and take a 5 minute break and then we'll push the rest of our time at the end. We'll take it at the end. So when we come back, we'll have right at 30 minutes to finish our content. So remember this recording still plays, so make sure you can turn your camera off, but make sure that you're on mute so we don't record. Sorry. See you at 9:06. All right. So we'll come on back and we'll push our other times toward the end. Let me see. Hold on. I'm trying to share my screen. Okay. So, how should the older adult go about getting a medication that a friend is taking that they believe will help them? So, they need to get that information about the name of the medication and they need to consult their own doctor, you know, because, so, as we talk, we're like, oh, okay, do you have osteoarthritis? What medications you found that help you? And so, just getting the name of the medication, but they do need, and we do encourage them to, mention it to their doctor. Doesn't mean that their provider will prescribe it for them, but, you know, they will at least talk to them about the medication. Older adults living on limited incomes may fail to take their medications or may make changes in the amount of frequency to conserve their supply. If someone is, if transportation is a barrier, not being able to get to the pharmacy certain times of the month, they might not skip some doses so that it can last them until they can get a ride to the pharmacy. So we do want to ask about any barriers. They may not refill prescriptions if they can't immediately see results. I've been taking this medicine. We may have even said it ourselves. I've taken this medicine for a whole month and I haven't seen any changes. So they may be reluctant about getting that medication refilled and continue taking that medication. But if you look at the meds, a lot of them takes like that 6 weeks or the 8 weeks for you to actually start seeing the effect of it. Some may even save old prescriptions just in case, or even share medications. And we want to talk to them about that. So looking at dates on medications, if the medication is expired, it could be harmful to the patient. It can be a problem if the older adults takes them again without consulting their healthcare provider. Sometimes they may even build up resistance. Like if they take a medication, they really don't need it. They take it because they had something left over, didn't take it as prescribed. They may even build up resistance. So the next time that medication is prescribed for them, it might not work well because that medication that their bodies have received built up that resistance. Okay. So we have an older client. They have been prescribed digoxin. The nurse determines that which age-related change would place the client at risk for digoxin toxicity. Okay. Is it a deep, and in the chat, you could put A, B, C, or D. Is it a decreased salivation and GI motility? Is it decreased muscle strength and loss of bone density? Decreased lean body mass or glomerular filtration rate? Or is it decreased cardiac output and decreased efficiency of blood return to the heart? An older client has been described digoxin. So go back through your files. What is digoxin for? How does it work? Um, what are some nursing implications? What are some client teaching? So that will help you to determine. Okay, now let's check your responses. Okay. They're at risk for digoxin toxicity, decreased lean muscle mass, because remember, if those kidneys are not working like they're supposed to, that medicine is not being excreted. Okay. So they have that decrease in that filtration rate. Got it. Medications that should not be crushed. Usually, pharmacy will have a warning on there, a label that says "Do not crush." So if a person needs medications crushed, then we need to look at. Usually, the doctor, or the pharmacist will look and see if there are some other medications that's just like that medicine that come in an alternate form, a liquid form. Because if we crushing those medicines and not supposed to, that means that medication is not going to be absorbed like it's supposed to. Because usually they have some type of coating on them, like enteric coated, or they may be extended release, and that's how they work. So if we're crushing that up, then that enteric coating is not protecting the insides of that person like it should, because we've removed that coating. And if it's an extended release medication and we crush it up, that person's getting that medication all at one time. It's not being released as it was designed to. So usually we look for and see if there is an alternative form of that medication to see if that medication can be given in liquid form. Okay, I'm going to read through these. Cardiovascular, there's a decrease in baroreceptor sensitivity, which results in a decreased adaptation to changes in blood pressure. So for the most part, things are decreasing you out. A decreased muscle mass and a decreased blood supply to the muscles are both musculoskeletal changes associated with aging. The neuro, there's a decreased number of nerve fibers, results in decreased reflexes. For the skin, decreased amount of melanin results in, so here, hence you have the gray hair. So for some, like in our family, we gray early. People have gray hair at 20 years of age, but the norm is that decreased amount of melanin leads to gray hair. So usually you see gray hair in an older person. Respiratory, there's a decreased tissue elasticity. So we talked about those alveoli, which results in a decrease in gas exchange. For the GI system, there's a decrease in peristalsis. So they're usually so that food and everything that we're consuming is not being broken down quickly and being excreted. So as a result of that person may have flatulence, they have gas, a constipation. So again, the GI system shows a decrease in gastric emptying and reduced enzyme secretion. So those foods are not going to be broken down like they should, which may lead to impaired digestion and absorption. So hence this person might have a decrease in appetite because they still feel full. So we might have to bring dietary in also. And so getting ready for the HESI exam, week 11, HESI geriatrics exam reviews, they are occurring and we will post the links as they are shared with us. Mine is Friday evening. Let's see what time it is. I think it is at, I'll put it in the chat. If Dr. Burke hasn't already posted it for everybody to see. And then, you have HESI geriatrics practice exam. It's in the week 10 module. Be looking at your basic geriatric nursing textbook and your HESI NCLEX PN book. Make sure that you go back through all these class recordings, you all. We've had week 6, 7, and 8, a lot of content. So make sure you're going back through these classroom recordings, just to make sure that you understand the different topics and concepts that we have actually talked about. And so let's see here. Are there any questions about any of the content? Generally, there's a decrease in what you know of the normal body functions for an older person. So, and even all the way down to gas exchange, the alveoli, the heart that, it's not pumping like it should because it loses that tone and that elasticity. So, and as a result of these things being slowed down, the normal processes, if it's not happening like it should, what would that result in? Okay, well, the person's, the VLI not doing what they're supposed to, that person's going to have, increase in respiratory rate. They have an increase in chances of getting respiratory diseases because that gas exchange is not happening. So we're teaching them to deep cough and deep breathe. They may have a harder time doing that because, those organs are not functioning like they should. So just kind of think about that as you're reading through and trying to decide what is the best response. Usually everything decreases. With those vessels, the arteries, you do have that hardening and that narrowing. And so as a result of that, that blood is there's a decrease in blood flow to the brain and the baby pinky toe. So if we're doing those head to toe assessments, we may see those alterations in that cognitive function. So can a client refuse medication? You can come off mute and say yes or no.
Yes.
Okay. Yes. So what do we want to do if a client's refusing medication? Do we just write it down and that's it?
No, you want to inquire what the reason behind them not wanting to take it might be.
Great. The nurse should first assess why the client is refusing the medication. We would identify any concern. There might even be misunderstandings or some type of barrier. Understanding the client's perspective allows us to provide any education that's needed, to correct any myths. So find out why. Why is this person refusing the medication? Okay. So we just talked about crushing medication. Can enteric coated tablets be crushed? You can come off
No,
mute. Okay. Can capsules be crushed?
no,
Okay. What about those buccal tablets, the tablets we put in the cheek?
no.
Okay, those medications cannot be crushed. They should not be crushed. We talked about several medication rights. The minimum, the basis is making sure that you have that correct or the right patient. There are some patients that have the same name and you are the same date of birth. It's like, wow, it didn't happen often. But in those facilities, if they don't have that armband on, we don't have those two. They can't tell you their name and date of birth. How do we identify this is the correct or the right patient? Making sure we have the right medication. Because, some patients are prescribed the same medication, but different doses, depending on the time of day. So making sure we have the right medication, the right dose, the right route, and then that we are administering at the right time. We usually have that hour before and that hour after. So you have that window. So to make sure that we are administering those medications and then making sure that we're going back and documenting. We talked about the decrease in absorption, like the bowels, their decrease in peristalsis. How does that affect anything? That decrease in enzyme activity that's in the GI system, things are just not broken down like they should. That the kidneys, they're not excreting the waste products. Okay. All right. And so let's see, what else? What else? We also talked about the liver, being that primary site for drugs breaking down. The liver does that metabolize into those medications. So if something's wrong with the liver, think about what the function is of the liver. So the main function of the liver is to break down these meds. If it's not doing that, what happens? Those medicines are sitting there. They're not broken down. They build up. And so they're not able to be excreted like they should. Like I said, think about what the normal process is. And if the things with aging, if they slow down, what could that potentially mean? Aging kidneys are significantly less effective at removing waste products because they become less effective in excreting those meds, you know, in part because there's a decrease or reduction in renal perfusion. So that means the medication stays in circulation longer. Therefore, you may see the different doses, a lower dose in older clients. So that decrease or reduced filtration rate may lead to, because they do know that the clients, older adults, have that decrease in that filtration rate, the doses of the medications more than likely are going to be smaller or a different dose. So the more medications a person is taking, think about OTC, supplements, herbs, and routine medications, there is a greater risk for reactions, interactions, reactions to happen. Drug interactions and toxicities in older adults are likely to. And then think about what we would see if a person is they're taking OTCs, they're taking herbals, and they're taking their routine meds. There's an increased risk for interactions, reactions. So what would we see when we're assessing this client? What might we see? We might see those cognitive changes. And we may think that this person has dementia, but in fact, it's because there is an increased risk of drug to drug interaction and adverse effects because they're taking all these different medications. So, because a person is taking all of these different medicines, there's an increased risk of drug to drug interactions and also an increased risk of adverse effects. So we may see those changes in those mental statuses. Person's not acting like they usually act because they have all these meds and they're bumping heads. The international units There are several medications, I mean, abbreviations that are on the do not use abbreviation list. And I don't know if you all have seen those lists in facilities. I know, like in the hospital, on there, in the some that are still using paper at the bottom of their doctor's orders, they have like a little legend as a reminder. Hey, do not write these out. Write these instructions out. International units is one of those. Um, Q day, the Q's were getting mixed up to be people thought the Q was something else. So the whole point though of the do not use list, because there were people were misinterpreting, like the nurse would come behind or the unit secretary would come behind and take off the order, meaning put the order in, and they misunderstood the abbreviation to mean something else. So in the event that there is to decrease the misinterpretation of an order or what the doctor actually has written or put in, the nurse need to contact that provider for clarification, and we need to request that correct spelling. Because if we put that order in and administer it as what our interpretation, then we have caused harm to that client. So we have to contact that healthcare provider and make sure for clarification and have them to spell it out. It's okay. We rather the doctor get mad or whatever, and we administer the correct medications the correct way to this patient rather than cause harm to that patient. Um, and so we talked about our clients taking all these medicines, but what if the client wants to just stop discontinuing medications without consulting their healthcare provider? So that is of concern too, because there are some medications that should not be stopped abruptly. That you just can't, you should not just stop taking them. So if a client is telling you that I just stopped taking that medication, because you do ask, well, hey, are you still on this medication? Are you still taking it? And if they tell you that they have stopped taking those meds, that is of concern. We do want them to consult with the healthcare provider just to make sure that this is a medicine that we don't need to taper. Because some medicines we have to taper down, like they'll decrease the dose and they'll decrease the number of times over a certain amount of days. So, what do we do to identify when we gotten the medications? We go into the patient's room, we knock on the door, they tell us to come in. What's that next conversation sounds like? What are we saying to the client? So someone come off food, we got the meds, we make sure we got the right meds and all that stuff. We knock on the door, they say come in. So talk me through administering those meds. What do we ask next, or what are we saying when we're in the room with that client?
We need to have them verify their first and last name and date of birth.
Got it. Asking the
Any
client to
allergies.
allergies, asking that client to state their full name and date of birth before giving those medications. Because even though we have the picture of the person, we got the name outside the door, even if they have that armband on, human error is a thing. Someone could have placed the wrong armband on that patient. We don't just go in and look at the armband. We want that client to state their full name and tell us what their date of birth is. Okay. We talked about refusing meds. I think we have covered. I'm sure we have. I know we have. Think about that from functional ability. What does me not being able to having full range of motion, how would that affect my balance? How would that affect me being able to eat, put my clothes on, things like that? So I do advise you to go back through our classroom recordings and make sure that don't look at all of them in one setting. Break it up, little parts at a time. And then think about that. Like I said, with functional deficits, am I able to brush my teeth like I should? If I can't do that motion of picking up and even squeezing that toothpaste out of that tube, that takes some movement. But if I have limited range of motion with my hands, my fingers, then I'm not even able to squeeze the toothpaste out. And then that motion, even if you have an electric toothbrush, you still have to be able to hold on to it. So the client may require assistance with mouth care and getting dressed. So think about, all of the movement, the things that we don't think about from day to day about, when we are doing things, completing our tasks. Are there any questions about any of the concepts that we've covered? Please go back through the classroom recordings. Are there any questions?
I have a question. Are you going to do a Kahoot for us? Or
We don't have one. I can ask Dr. Work is there if there's one, because we usually get that from a course lead.
Mhm.
I can ask if there's one available.
Okay, thank you.
Hmm.
I have a question.
Hmm.
Does the HESI practice exam count towards our grade at all?
I'm not sure. We have to go back to our syllabus. Let's look at the syllabus. Let's see. What does the syllabus say? Let's go to your module. What other questions do you have? Well, I'm looking to see what the syllabus actually says.
So when we do the practice HESI test, if we're having like, say we did bad on it, will we be able to meet with you like one on one, or is there anything that you can do to help us?
Yes, of course, we can talk about the concepts. Exactly. We can meet and talk about the concepts. But we'll go back through like your classroom recordings. We'll look at your PowerPoints. And so that info you have to be able to understand those concepts. But yes, we can meet. But what we'll do is go back through our PowerPoints and those concepts that are mentioned in the PowerPoints because it is there. You are. I assure you, we go over all this content, but just take it and think it through. So if it's an older person, think about what the normal body function is for whatever that concept is, whether or not it's the heart, the kidneys. And if it's older, these things slow down. What will we see? But yes to your question. We will
Okay.
be able to meet, but we'll go over the PowerPoints and everything that's been provided for you. We'll just talk back through those again. HESI practice adaptive quiz. Let me look at, I'm still looking at the syllabus. Are there any other questions? And let's see here. Mhm. And so beyond, even in between terms, you want to just continue to be looking at NCLEX questions. You know, I know you're looking at doing this information now because it's part of your grade, but you still need to be looking at NCLEX questions, reading the rationales for that's the quiz number 5, right? Is that looking at this right? Looking at rationales for the correct answer and also rationales why the incorrect answer doesn't match that question. Because both ways you learn, you add more information to um, your files. You have to know the concepts. If we don't know what the respiratory system does, and it's kind of hard to explain or pick out answers for, I don't think so. You are. I'm look one more place about if someone has a respiratory disease process. We don't understand what the respiratory system does for us. And when we say, well, this person has something wrong with their lungs don't inflate and deflate, but we don't understand that it's a gas exchange problem, then that we're not making that connection. I'm looking one more place for that. I don't see, and it's not in your grade book, but all of these things, resources are there to for you to identify was not, hey, I don't really understand these concepts, or I do understand these concepts. So it's there to strengthen your foundation. There aren't any more questions. You are free to go, and we will see you on. Don't forget if you want that exam proctored, make sure that you found the proctor. Send the email to myself, Dean Brown, and that campus dean because they want to make sure that they have everything set up for you. Put
Is
all
this
this in
the
the
last
email.
week of the quiz homework?
Oh yes, this is pretty much it. Let me look and see. But yeah, let me go to the modules. You have a quiz 5. You say quizzes, right? You say
Mhm.
quiz? Yes, let's see.
This is the last week, or we have another one next week?
Let's see. This is week 9. You have quiz 5 this week. This is it.
Okay.
Yes, quiz 5 is the last quiz. Next week is unit exam and then history.
Okay. Thank you.
I'll take the time. Y'all are going through those quizzes mighty fast. I mean, you might know if you know the content, that's good.
Yeah.
But make
Oh, you
sure
see my
because
grade? I went through it too fast the last time. I don't know.
and again with the exam, make